So, last one, look how we have not had a bread and butter pulmonary nodule talk. It's chest all day. You're probably feeling deprived. Now is the time. So the reason I put together a very exciting bread and butter pulmonary nodule talk is because, pulmonary nodules are very varied. We did actually talk about a number of them along cysts, cystic ones, etc. But there's a plenty of other nodules. These are not the same looking, but what is the most likely thing in a report? Non-specific. Clinically correlate. This does not help. So how do we become helpful given nodules do actually look different from each other and have different risk? There's a couple things we can do. We can look for definitely benign features, so we're not worried. If it's not there, we can give follow-up recommendations. And if it's not small, then we can help assess the risk. And that figures out the next step collaboratively. So that's what we're going to go over. Definitely benign features, small nodule follow-up, and assessing the risk. And since I do have this PET background, we're going to talk a little bit about PET like we did in my lecture yesterday. So let's dive in. Definitely benign features where we no longer care about the nodule. We have a list of them. I'm going to go through each of them together so we don't have to read this. So we're going to start with number 1, benign calcifications. These are the classic solid calcification, central, any sort of ring or target-like pattern, or, the standout weird one, the popcorn of hamartomas. So everything else then is not definitely benign. Stippled is not good. Eccentric, I know this was a benign case, but that is not a benign calcification. Irregular, or if the nodule just is scary and bad looking, it doesn't matter that there's a central dot of calcification. Not definitely benign anymore. Second is fat in a pulmonary nodule. Here's a pulmonary nodule off the right hilum. I don't know if there's fat there, but if I use a soft tissue window, it looks like there's macroscopic fat. I can even measure it. I could get a fat density, and then done. Macroscopic fat, definitely benign feature. Next, a long-term stable pulmonary nodule, definitely benign. Now what's long-term? For solid, we're currently using 2 years of no change. Subsolid, our guidelines say 5 years. I think this is actually a tough area. I'll tell you why I am not super comfortable with 5 years. Here are 2 examples of ground glass lesions. Saw this in my former practice, and both of them exploded to be terrible invasive cancer in something closer to 8 years. So we have seen these sort of ticking time bombs sometimes take longer than 5. Now our guidelines say 5. There has been some papers trying to evaluate this. So this paper did look at what happens after 5 years. Turns out most don't change, so 98%. The tiny amount that did were on the bigger side. They did not kill people. And the end sort of conclusion was, why don't we recommend a single one-time follow-up at year 9? That's not actually going to happen. How are we going to make that occur? I have no idea. So that's not official guidelines. I'm just saying let's keep an eye on this long-term ground glass thing. All right, next, definitely benign features. I sort of added this based on our guidelines, a small nodule in young people. So what does that mean? Well, our guidelines for small nodule follow-up are up to 8, so let's call small 8 or smaller. What counts as young? It is basically my age or younger. And that will be true forever. Actually, I actually was 35 once and practicing, not anymore. The guidelines actually say 35 and above for Fleischner. Okay. Periphyseal. So interestingly, periphyseal nodules, definitely benign. You would think that'd mean there'd be the fissures, but actually that's only a subset in our literature of the super typical periphyseal nodules. So these are supposed to be homogeneous, solid, smooth margin, a specific shape, okay, sort of like the lens or the triangle, And typically, it would be on a fissure. Okay. These ones are a reasonable proportion of nodules. They can be teeny tiny to reasonable size. They can even grow. And every time they've tried to study this, no cancers in these cohorts. So our official Fleischer Society says follow-up is not recommended. It is actually in this 2022 sort of guideline for lung rads as a category 2, as long as it's small enough. But you can see the guidelines are not super homogeneous. There is all this debate about non-classic ones, so it's still an evolving area. If it does not meet one of these definitions, then we have to keep following, okay? A super round lesion will follow regardless of it being on the fissure. Indistinct borders or completely eccentric, that's not classic enough. We follow those. All right, those are our 5 definitely benign categories. And if it's not definitely benign, what do we do next? If it's small, we can at least suggest when do you follow. In the old days, we had this beautiful, simple table. I loved this thing. I had it up near my PACS. I put it above my bed. It was everywhere in life. It was very sexy, yes. It is now dead. Simple table gone. In place of it, we now have this much larger table. Now, hard to memorize, much bigger, but has some benefits. Now we have solid and subsolid together, but of course, harder to memorize. One of my least favorite parts are these optional CTs. It's supposed to be based on joint decision making. Well, we're not usually involved in that. It just leaves open, variability. What is good is it now has risks and the density and how many. Can't really memorize it, but a key number is 5 millimeters. It's usually that or smaller when we don't bother following nodules. In the paper describing this bigger table, they did answer some nice questions for us. For example, if we know a nodule is just here or there in the lung, should we just scan that part? The answer is no. It is too much work to try to capture it. They might miss it. Can we check it in time? So we just do full chests as follow-up. That's what we do. And what if we catch a nodule on a neck or an abdomen? When do we get a full chest? What they said is you should get a full chest right away if it is large or suspicious. And large was unspecified. So I'm going to call that the 8 millimeters of the upper end of Fleischer. All right, so we can follow. If it is not small, then what's left? What do we do with these larger, suspicious, big ones? We technically have 3 options, right? If we think about what is the higher level next step. You can keep getting follow-up. That's the most conservative. We can get PETs, very expensive, lots of radiation, or a biopsy, which do have invasive complications, right? So if something is not small and not definitely benign, we have to figure out which of those very variable next steps. And that is where we assess the risk of malignancy on our side, combined with the clinical side, and we figure out the next step together. So I'm going to go through the features of bigger nodules and how do we assess the risk. Of course, the biggest is size. Once it gets bigger, size is still a factor. So let's think, what are the risk of pulmonary nodules that are below 4 and 4 to 7? What's the chance of those actually being cancer? And think about how much of my life I've spent on 4 millimeter nodules. What is the risk? Almost nothing. So maybe a bad use of my time, I don't know. So tiny nodules, super unlikely. And once they get bigger, the risk really starts climbing, okay? So a medium-sized nodule, like in the middle there, has a reasonable chance of cancer. This one was. Teeny tiny, should definitely not be cancer. This is the one counter example. In fact, the only times I feel like I've caught incredibly teeny tiny cancers are METs and when there's many. That big, huge one, that definitely should be a cancer. And this is the counterexample there, which is a very specific type of infection with all this scarring, but generally should be cancer. Okay? All right, related to size is growth. And the idea is if you can prove slow to moderate growth, that is classic for cancer. So here's a teeny tiny nodule. We just saw the chance of cancer should be low, but we did have a prior and it grew. We had a prior before that and it grew. We had a prior before that, it still grew. This is slow to moderate growth. This is basically definitely a cancer, even though it's small. Okay. This thing should be cancer. It is a huge, ugly looking mass. We have what look like mets all over the place. But this thing, the history that came to us was something acute. We had some sort of imaging prior and there was nothing there. So fast growth, it probably should be something else, and this was an infection. Another example, this is a medium-sized nodule, but not a nice-looking one. I'd sort of say chance of cancer pretty reasonable, but just a few months prior, nothing. That means the doubling time was super fast, too fast for cancer. So instead of going down the biopsy crazy route, let's give it a little bit of time, and this thing started getting better in just a few months. Now, when we talk about growth, I do like to talk about the opposite. What if a nodule decreases in size? Usually, if a nodule gets smaller, that means it's an infection, right? We are quite reassured when that occurs. But I like to point out, because it's dangerous, a single time point decrease in size by at least some could happen in cancer. So just one follow-up and a little bit decrease, we need to still be worried. So here's my example, a nodule by a cyst, just described. This was worth following, and it grew in some period of time to be much, much larger. A biopsy requested, totally reasonable. When the person showed up for a biopsy, though, it was clearly smaller. That is common with infections, so maybe we don't go ahead with the biopsy. Also reasonable. But because cancer can get slightly smaller in one time period, we must follow. We did, started growing again, and then fine. We pull the trigger on the biopsy. The whole time, this was cancer, and yeah, it did wax and wane a little bit on its path to growth. One more. This was a small mass, or nodule rather, off the hilum, clearly hypermetabolic on a PET, got smaller on its own. I was so sure there was treatment. It had to be. I looked up the chemo. There was none. This was an untreated cancer that got smaller on its own a little bit, path proven, before it just continued growing on its own. And this is because the body does try to attack cancer. It just always fails. All right, we talked about size, growth, and decrease in size. And interestingly, it all requires you to measure a nodule. Sounds pretty straightforward, right? You just use a little ruler thing on PACS and that's it. But we actually have created a many page paper about how to measure a nodule. So that does mean there's at least some questions out there about it. So why don't we try to answer the key takeaways from it? When we measure a nodule, we should be doing it on thins. So that means 1.25s or 1s or less. We should have it reprocessed in the sort of lung type algorithm that's at least somewhat sharp. It should be, if possible, an inspiration and looked at on a lung windows on a viewer. Okay? We measure the long axis, and if your PACS does spit out the 10th or 100th or 1,000th of 1 millimeter, that's not really realistic, so we can round that sucker up to a single millimeter. On the same slice, we should do the 90-degree angle, average it, and again, there's no tenths of a millimeter. Let's not be crazy. We round it back up, okay? If it is a relatively small, meaning less than a centimeter, we can just give that one number, even if it's oblong. Once it gets bigger than a centimeter, fine. Give 2 measurements in case it's oblong, all right? What I love about this paper is it helped answer the issue of change. What counts? Turns out if you and I measure something, we're not going to get the same number. So we're going to call change 2 millimeters or more. This is great. We can now get rid of this 1 millimeter up and down business. They added some vocab words I like. You can actually call teeny tiny nodules micronodules. And when you have a nodule that has ground glass, it has reminded us we should actually measure both the ground glass and the solid. I thought that was helpful. All right, so there's some of the takeaways from a 10-page paper, but read it if you'd like. Lots of fun. All right, that's size. Next is border. And the big take home here is that spiculation is bad. Okay? Often it is indicative of something in the cancer spectrum. Why? It either is the cancer spreading along lymphatics or causing a sort of fibrotic reaction, which leads to that spiculated appearance. The one differential key is if it is a granulomatous process, like that one huge TB mass I showed you, but it is a risk factor or suggests that this might be cancer. Next, cavitation. Classic teaching is thin-walled cysts are more likely to be benign lesions than cancer with cystic space. But if it is thick-walled, we just had a whole lecture on this, so I'm just not going to go into this in huge detail, more likely cancer. That is the classic. The classic sort of cutoffs taught then leave this sort of gray zone in the middle. Now, super classic is that if it's very, very thin-walled, it's even more likely to be benign, like this infection. I found the sort of counterexamples do tend to be more likely in this sort of metastatic category, specifically like gyne or other cancers that do it. Now, interestingly, I have learned this. I find it helpful in the extremes. There are papers that just say, there's no point. You can't really tell. I think the extremes are helpful. It's something I keep in mind, but there is debate. Next, and this is a classic question for chest radiologists. I love it. If you have two totally separate patients, and one has solid, one has ground glass, and they have nodules of the exact same size, first diagnosed, never seen before, which patient, A or B, is more likely to have a neoplasm? I remember this being asked of me. I remember thinking the wrong answer, which was the point. And so the answer is ground glass opacity. Why is this such a question we love to ask and to trick people? Here's the data, and I'll say why it's true. If you have the same size nodule, it is more likely to represent neoplasm if it is a single ground glass nodule than solid. Why is this so tricky? It is true if you have ground glass nodules, of which there are not that many in the world, right? If we scanned everyone's lugs, there's not that many. It is true they're more likely the sort of adenocarcinoma spectrum type lesions, probably more common than a weird random infection. But we are actually used to seeing tons and tons and tons of solid nodules. Now, most are benign, but it is also the ones that we see as cancer. And in fact, it's the more aggressive ones. It's the ones that we burn in our brain and we remember. And so we're used to seeing solid. We think of lung cancer as solid. So that's why we love this question. But if you happen to have a ground glass, while less common, we need to be worried that it might be one of these neoplastic lesions. Okay? So these ground glass nodules, I think 20 years ago, we maybe even ignored them or said we don't know what to do, but we don't ignore them now. We do make sure they stick around, right? The actual first time you see it, the right workup is to at least do one more to see if it is transient, to see if it is infection, to see if it goes away. If ground glass nodules stick around, basically stay the same or grow slow, now really high risk of something neoplasm. I keep saying neoplasm instead of cancer or malignancy because they can be the in situ versions of adeno, but it is something that we do not ignore. We actually follow these and see if they grow. All right, that's it for CT features, and then we're going to end with PET features. Even if you don't read them, we can think about when is PET useful or how does PET factor into our thinking of nodules. The basic principle is pretty straightforward. Hot nodules are risk, cold nodules are not. So when does it not work? These low density in situ sort of spectrum lesions tend not to show up. Indolent tumors tend not to. And we just heard, ones that have lots of air or in the abdomen, lots of fluid or mucin, they should not light up. So these don't work well. And of course, the flip is other things can light up, right? Particularly aggressive or medium aggressive infections will show up, okay? And they can be pretty bright, actually. So the whole magic in the reading and the value of PET is what counts as positive, okay? So what are the sort of options? We could just do a qualitative. Is it relatively bright compared to something? Lung, mediastinum, something else? Actually super discussed. I still get questions about this. Is a number like, ooh, 2.5, right? 2.5 is the cancer number, isn't it? So this is what people talk about. What do I do? Where's the magic here? I think the way to answer the question is to think, well, what do we want this test to do? Do we want a PET of a nodule to be a low threshold test, meaning anything slightly positive? That means we're going to get aggressive cancers, we're going to get so-so cancers, but we're also going to get all the infections that light up, right? We're going to overcall, but catch all the cancers, or most. Or we can be slightly discriminating here. We say, no, it needs to be sort of bright. I only want the badass cancers. That will confirm aggressive cancers. We're not going to get as many of the infections pulled in, but we're going to miss cancers as being positive. So which do we want? The answer is we don't need that high threshold thing. The confirming aggressive cancer is not us, right? We put a needle in it, we get a pathologist. That's the answer there. What we want with this test is actually something that's very sensitive. We actually pick up most cancers. And the reason we want it is because if it is negative, then we are reassured and maybe we don't go down the crazy biopsy path. That's the point. So if you do be sort of discriminating, I only want the really bright ones, we are still not going to get all the cancers, right, the indolents, and you're still going to overcall some infections. It is a mediocre test. But if you start making it any activity at all, we're going to get most of our cancers, high sensitivity. Sure, we'll overcall some stuff. That's fine. Put a needle in it, we'll get an answer, okay? So my recommendation, the way I read the sort of magic of PET is to use this lowest threshold idea. So I call it anything detectable above lung. If I see a dot there, I say a slightly higher likelihood ratio is a positive test. Okay? So let me show you how it plays out with those likelihood ratios if you do anything above background. Let's say we have a medium-sized nodule, a 40% risk, a so-so risky. If we have a positive test, it is now more likely cancer. It's still not a guarantee, and that's fine, because what will we do now? We get someone to put a needle in it. Okay? But if it is negative, we're super discriminating. There's no activity. This thing is stone cold. It is the background lung, nothing. Then our chance of cancer is super tiny, no matter how big it was before. At 2%, we would be comfortable with ourselves or our family members saying, let's just get a follow-up CT. If it is cancer, it should grow slowly because it's not that hypermetabolic. And that's how we use it. Okay? So this works. It is a approved covered indication by CMS, as long as it's 4 centimeters or smaller. The issue is we're pretty good at CT. We just had a whole lecture on the size, the calcification, this, that, the other. We can usually assess risk just fine. So we don't often have to go to PET-CT in every single nodule. I find that it helps with basically troubleshooting cases. High surgical risk, lots going on, we don't really know. Let's have one more factor to throw in the decision making. Okay, when we talk about PET with pulmonary nodules, couple side questions. One is, can you use the same thought process for metastases? I.e., is this nodule a metastasis or is it benign something? Basically, it's the same sort of process with PET and the same analysis. The only difference is to think about what kind of cancer we're talking about. If it's an indolent tumor, they're probably not going to light up. So it's just not that helpful of a test, or I would say a very, very low threshold might be positive. But if it's a very aggressive, untreated tumor, like a melanoma, that thing should light up. So if even a small thing does not light up, I don't know. Then I'm a little bit less suggestive if it's a MET, because I'm expecting it to be super bright. The next question people ask a lot is, well, what size nodule can I recommend for PET? And they say, like, how low can you go? This, by the way, immediately makes me think of limbo. And so I Googled some limbo, and look at this crazy picture I came up with. This guy is not a very exciting limboer. Not only is this not a very impressive limbo height, look at this limbo set. It's like fake grass in the bottom. He rented a room in a basement of some church. There's no windows, crazy ventilation, and someone's holding his hand. This is cheating. So we can definitely go lower than that with our pulmonary nodules. Classically, people say, 1 centimeter, because PET resolution is somewhere in the 5 to 7 millimeter range. But really the answer is, it sort of depends, okay? If this is a melanoma, if it's towards the apex where the lung doesn't move much, you should be able to see a pretty small nodule. But if it is an indolent tumor, if it's by the diaphragm, it's moving all over the place, I don't know, you might not catch 1 to 2 centimeter nodules at all. All right, so for our pulmonary nodules, the best topic ever in chest, we have now covered definitely benign features, how to follow up nodules if they are small, and then how to assess the risk if they're big. And that is it. Thank you very much.